We're now going to discuss specific poisonings. We talked about general management. We're going to talk about specific poisons. Not all of them have antidotes. Sometimes it's just supportive management, but certainly we need to know how to diagnose or how to suspect which poison it is through toxidromes, and then we'll go through specific management. Acetaminophen is a commonly taken medication. It is hepatotoxic, although children tolerate it fairly well. Remember, the magic number is 150. They will probably not give you a nomogram, but they might tell you a level. Acetaminophen peaks at about 4 hours after ingestion. And so a level higher than 150 will falls in the nomogram in the area of possible to probable hepatotoxicity. Under 150, you're probably safe and you don't need to give treatment. It's very important to know that number because there is an antidote for acetaminophen, and so you need to decide whether to treat or not to treat. So at 4 hours, 150, that's the magic number. Hepatotoxicity usually doesn't occur right away. There are 4 stages of acetaminophen ingestion or intoxication or poisoning. The first 24 hours, the patients may have nausea, some vomiting, nonspecific signs and symptoms. The next 24 hours is what they call the honeymoon phase, where clinically they look better. The patient feels better. However, that's when you're going to see some problems. If the patient is going to develop liver problems, that's when you're going to see an increase in liver enzymes or liver function tests. The next stage is 72 to 96 hours. This time, that's when it's going to peak in the liver function abnormalities. And then after the 96 hours is basically the convalescent stage where the patient gets better and resolves. This is the nomogram. Again, you don't really need to know a whole lot of numbers, except remember 150 at 4 hours. That's when the patient is really in trouble for liver problems. Always in females of childbearing age who come in with any kind of intoxication or ingestion, always get a pregnancy test, regardless of what medication or what thing they did to themselves. Specific tests for specific ingestions. In the case of acetaminophen, we want to get the level at least 4 hours post-ingestion, and we want to then get liver function tests, and you get them daily. The initial liver function test in the first few hours after ingestion should be normal because they don't have any liver problems yet. Afterwards, then you need to get them daily, and that's when you might see a bump and a rise in the enzymes. There is a specific treatment for acetaminophen toxicity, and that is N-acetylcysteine. It is best given within 8 to 16 hours after ingestion. It is usually recommended even afterwards, but you get better results within the first 8 to 16 hours. So you see that you do have a little bit of a leeway in getting your levels back in deciding whether to treat or not treat. Once you start treating, though, you are really committed to treating. You have to give the entire course, because subsequent levels of acetaminophen, once you start N-acetylcysteine, are of no use to you. They plummet, and then they will be in the non-toxic range, but you are obligated to continue treating. You may get one follow-up level just to make sure that it has gone down. If it hasn't, you may need more treatment with N-acetylcysteine. They will not get into how much to give, how often to give it. You just need to know that you have to give it. Alcohol. There is no antidote for alcohol, unfortunately, and the effects depend on the level. In all states in this country, a level of 0.08 means that you are legally drunk. And so you need to remember that number, because when they give you that in the exam, you know that they are legally drunk once they give you the level. This chart will show different effects at different levels. There are a lot of factors that influence the signs and symptoms of alcohol intoxication. For example, the size of the patient. A smaller patient will require less alcohol to get intoxicated. If the patient has had food with the drink, then it takes more alcohol to get the effect. If the patient is a chronic drinker, then it might take longer for them to have effects of the alcohol because they have developed some tolerance to it. So you have to take those into account with the particular person. A level of 50 to 150 will cause just some lack of coordination and blurred vision. 150 to 300 will cause visual impairment and slurred speech. 300 to 500 can cause hypoglycemia. Remember that as part of your management. You need to be careful about hypoglycemia. And a level of greater than 500 is potentially fatal, particularly in someone who has not built up any tolerance. Amphetamines are a stimulant. They're easily obtained in schools because a lot of children are on stimulant medication because of their attention deficit hyperactivity disorder. So sometimes it's a very popular drug to use. Acute intoxication with amphetamine, symptoms include diarrhea, palpitations, arrhythmias. Chronic use, you can see restlessness, nervousness, depression, and they can be suicidal. The best test is a urine drug screen. And that will give you a qualitative test. It's not a quantitative test. It doesn't tell you how much is in there in your system, but it does tell you that there is some in your system. Okay. The next is aspirin. This is the most common drug poisoning in this country. Typically, you'll see aspirin poisoning in older patients, particularly the elderly, because they're on that medication anyway, and sometimes they take more. The presentation depends on the age. It's going to be a little bit different in children compared to adults, so you better make that distinction. It also depends on the age of the child for the presentation of symptoms in children. The mild intoxication, they can have vomiting, fever, lethargy. Severe intoxication will cause seizures, coma, and dehydration. And the chronic ingestion will cause hyperventilation and tinnitus and dehydration. The chronic intoxication is what you're going to usually see in the elderly. Children most likely would just grab a handful of the stuff and take it all at once. Again, the magic number is 150, although there is no real antidote here. So an acute toxic dose is greater than 150 milligrams per kilogram of ingestion, so that you have to kind of be a detective. You have to get a history of, well, how much does the patient weigh? How many pills did the patient take? What size pills are there? Sometimes you don't know. You have to say, okay, how many pills are in the box? How many pills are missing? And you figure it out. So a dose of greater than 150 milligrams per kilogram is an acute toxic dose. The stages go as this. First, you'll have a respiratory alkalosis. What happens is that you have a direct stimulation of the respiratory centers, and so patients, children, will develop a respiratory alkalosis. They then have a paradoxical aciduria. So if you get a urinalysis, even though they're alkalotic, the urine will be acid. Later on, they will develop a metabolic acidosis. In this case, physically, they will have tachypnea. Not because of direct stimulation of the respiratory centers, but because they're trying to compensate for the metabolic acidosis. And one of the signs of the later stage is what's called Kussmaul breathing. Now, we mentioned Kussmaul respirations when we talked about diabetic ketoacidosis. Well, this is a metabolic acidosis, just a different cause, and they will have Kussmaul respirations. So remember, it's a little bit different in children. First, it's a respiratory alkalosis from direct stimulation of centers, then paradoxic aciduria, then a metabolic acidosis, but reflected by compensation with Kussmaul respirations. Labs, you get a CBC and electrolytes. Look for the platelets in a CBC. A blood gas to help you with your acid-base status. There's a quick test that you can do called the ferric chloride test. You take a drop of urine, put it on a ferric chloride tablet, and it changes colors. It does not tell you what your aspirin level is, but it does tell you that there's aspirin in that patient's system. We don't really use the nomogram anymore because it just tells us if what kind of ingestion it was. There's really not a treatment for it, so it doesn't determine whether you need to treat or not. The treatment is supportive and sometimes may require actually dialysis. Carbon monoxide is not really an ingestion, but it is an inhalation, and it is a poisoning. Sources of carbon monoxide include a faulty car. For the child, they're driving in the car, and carbon monoxide fumes can go into the car itself. or some problems with heating in the house. Very rarely are you going to have carbon monoxide poisoning in a child that's intentional, where they drive the car into the garage, close the door, leave the motor running. Carbon monoxide has a high affinity for hemoglobin. It displaces oxygen from the hemoglobin molecule, and therefore it's difficult for oxygen to get to the tissues. The affinity is 250 times that of oxygen for the hemoglobin molecule. The best test is to get a carbon monoxide level. That is the best test for carbon monoxide poisoning. The signs and symptoms depend on the level. So you can see that a 0 to 10% level, you may not have any symptoms. In fact, smokers are running around probably with a 3 to 5% level, and they're not showing any symptoms. You start seeing symptoms later on when you're above 10%. So look for a history of a patient with somewhat bizarre behavior, and look for a history of exposure. And then you need to get a carbon dioxide level. The treatment is going to be oxygen. You can also get a urinalysis and look for myoglobin, because sometimes they have rhabdomyolysis. The cherry red blood is not pathognomonic, but sometimes when you draw venous blood for your lab work, you see that it's really bright red. It's not pathognomonic, but it could be a helpful hint when you're taking the test. And basically, you're going to treat with oxygen. Not everybody has a hyperbaric oxygen chamber, so oxygen is fine. It helps give higher concentrations, and it decreases the half-life of carbon monoxide from 250 minutes to about 47 minutes. Even one exposure can cause symptoms later on, such as behavior changes, headaches that are persistent. Look for rhabdomyolysis in the immediate period. The caustics include acid and alkali. These are things like liquid plumber, Drano, those kind of things that many times patients or toddlers will get into. They will cause mucous membrane burns. They can cause drooling and pain. The labs are nonspecific, and the treatment is basically supportive. There's an absolute contraindication to inducing emesis, because they will be vomiting up acid or alkali, also to lavage, and it's a relative contraindication for endoscopy. If the patient has drooling and burns, then you have to do endoscopy to see the extent of the injuries. You may have a patient that swallowed some of it, and they don't really have or took some of it. They don't have much burns. You don't need to do anything except observe them. However, if they have burns in the mouth, you have to assume burns further down, and then very careful endoscopy is indicated to see the extent of scar of injury. Cocaine is often mixed with other drugs. That's the first thing you have to remember. So it can sometimes be cut with other drugs. So if you're taking one drug, you may be taking more than one. They can be restless and agitated. They can actually be hypertensive, and later on they develop hypotension. A perforated nasal septum can occur from repeated sniffing or snorting of the cocaine. Remember, it's probably the most potent vasoconstrictor that we know, and it can cause ischemia to the nasal septum, and it perforates. Sometimes you will see cocaine ingestion or toxicity from a body packer. When one of those bags breaks in the intestinal system, they then absorb a lot of it all at once. Cocaine is recently being brought into the country via formula, powdered formula. They put it in the formula for the babies and sneak it in that way. A urine drug screen is usually required to get a positive drug screen. Means the patient's been exposed. And cocaine is very quick acting, so usually it's supportive care for a short period of time to get them over the worst of things. Hydrocarbons are very commonly asked on the exam. They aspirate rather than ingest. Hydrocarbons will be found, for example, in kerosene. It doesn't taste the greatest. A baby might drink some of it. Not a whole lot's going to get into the stomach, but then the fumes can cause the problem and cause an aspiration problem. So you do not want to go in and induce emesis. You do not want to put an NG tube down. Patients may present with an aspiration pneumonia. If they have no findings like crackles or wheezes, you still need to observe them for at least 6 hours. If they have no symptoms or signs, then they can probably go home if you think the environment is safe. Otherwise, you may actually hear crackles initially, and that's suggestive of an aspiration pneumonia. There is no specific treatment except for observation, but again, you want to avoid lavage with this. This is a super duper ultra mega high yield subject, the organophosphates. Organophosphates are acetylcholinesterase inhibitors. They can be found in insecticides. Also look for a child that has been playing in a recently fertilized field like a rose garden or something like that. And this is a nice quick mnemonic for organophosphate poisoning. It's called dumbbells. The D stands for diarrhea, the U is for urination, the M is for meiosis, B is bradycardia, E is emesis or edema, as in pulmonary edema, and L is lacrimation, and the S is salivation. So you can see that this is what we call a hypersecretory state. Look for exposures. Sometimes it gets on the skin, and so part of the treatment is to wash the baby, get the stuff off the skin because it's being absorbed through the skin. A really good lab test, if they ask you for one, look for red blood cell cholinesterase activity. It'll be decreased. Now, this is usually a send-out lab. You're not going to get the results right away, so you need to initiate treatment right away. And the best drug for treatment is going to be atropine. It's not an antidote per se, but it does take care of the symptoms. Pralidoxime is an antidote, but it's used only for certain organophosphates. The carbamate esters do not respond to pralidoxime, so the drug of choice will be atropine. Iron toxicity or intoxication or ingestion sometimes occur, not from the children's preparations. Typically it occurs from adult preparation. So they can drink grandma's iron supplement, or they can get into mom's prenatal, postnatal vitamins that have iron. Those are the ones that can cause trouble, not the children's vitamins. 60 milligrams per kilogram is the magic number as far as a toxic dose. Iron also goes along with certain stages. The first stage occurs 30 to 60 minutes after the ingestion, and it includes nausea, vomiting, and it can mimic a hemorrhagic gastroenteritis. Now, we talked about hemorrhagic gastroenteritis a little bit earlier in the GI chapter when we talked about like Shigella, Salmonella, Campylobacter. It will mimic that. This could be iron. At about 6 to 12 hours, it also has a honeymoon phase where the patient clinically feels and looks better. But you still need to observe them because later on they can actually have shock and cardiovascular collapse. The fourth stage is about 1 to 2 months after ingestion, and that's when you're going to see GI scarring and obstruction if it's going to occur. The best test here is a serum iron level, and it should be done 4 hours after ingestion, and the magic number here is greater than 500. If its a level is greater than 500, that is toxicity. Sometimes on abdominal film, you can actually see radio-opaque particles, and that's because the iron is dense, and so it's a metal, and it's radio-opaque, and you'll see that throughout the intestines. If the patient drank an iron preparation, however, the liquid preparation, you won't see anything like that. The treatment is deferoxamine, so there is an actual antidote. We also have discussed prior chapters the use of deferoxamine for iron overload secondary to hypertransfusion. Antihistamines, sometimes these will be combined with other medications, so you can have different signs and symptoms. They can stimulate or suppress the central nervous system. One of the things that you'll see with many medications or after many ingestions or intoxications is that you can have hyper or hypokalemia, hyper or hypoglycemia with the same drug. It will affect many different organ systems in many different ways. CNS changes are part of a lot of ingestions. In fact, you have to consider ingestions as part of your differential diagnosis in a patient with mental status changes, possibly secondary to encephalitis. Ingestions are they kind of act a lot alike at times. They can have drowsiness or insomnia. They can have nervousness or restlessness, or they can be hyperactive, hallucinate, and have seizures. Some of these medications can have alcohol in them, although most of the children's preparations are now alcohol-free. But some of the medications come with decongestants. So the decongestant can actually make them have tremors and tachycardia, and make them even more restless. Also remember, they can come in sustained release forms, so you can expect the signs and symptoms to last a lot longer. There's no specific treatment for antihistamines. You simply have to just do supportive care. Barbiturates are a common form of poisonings in children. One reason is that we still use barbiturates for seizure control in children. So sometimes the child may get into, like the older siblings, barbiturates for that child's seizures. So sometimes you will see that in the household. They will depress respiration. They can cause hypotension. They can cause mental status changes, make you very sleepy at times and unresponsive. And the treatment is going to be supportive. You can do a urine drug screen for barbiturates. Tricyclic antidepressants. We have these medications everywhere, and again, sometimes it could be in older siblings. Don't forget that sometimes we use tricyclic antidepressants in the treatment of enuresis. So they may be available in the house, or someone else in the house may be taking it for a valid reason, and the younger child gets into the medication. They cause sedation and alpha blockade, and it's an anticholinergic. The two things that you really have to look out for with tricyclic antidepressants are seizures and arrhythmias. They can present with seizures, and an arrhythmia can kill them. So all patients who have tricyclic antidepressant ingestions need to be monitored, and you need to have EKG, continuous EKG monitoring while they're in the hospital. Look for a widened QRS complex and a long QT. The treatment is basically monitoring and supportive. You can try bicarbonate, or you can also, if they do have arrhythmias, you can treat with lidocaine. We're going to go over some specific toxidromes, which are actually in a chart, and this is based basically on organ systems and the major drug type. So as you can see, we're going to divide organ systems into pupillary changes, central nervous system changes, cardiovascular, skin, and what happens to bowel sounds. And you can use this somewhat to help you on determining what drugs they got into, in addition to the things that we've already discussed. The anticholinergics will create large pupils. The sympathomimetics will create large pupils, but they'll be reactive, whereas with the anticholinergics, they're not reactive. The anticholinergics, for example, like atropine. The cholinergics will cause small pupils, and the opiates will cause a pinpoint pupil. CNS, you'll see confusion with the anticholinergics and hyperactivity with the sympathomimetics, lethargy with cholinergics, and depressed sensorium with the opiates. With the opioid medications, remember that naloxone is the treatment of choice, and it will reverse the symptoms. The other thing to remember as a guideline is that the antidotes that we use for certain medications are never as long-acting as the actual medicine they got into. So, for example, if you have a patient that comes in and you suspect opioids and you give them naloxone, that's going to reverse, and you say, wow, that's great. Keep your eye on them because it'll wear off and they'll still revert to the old signs and symptoms. Same thing can happen with benzodiazepines. You can give them flumazenil as their antidote, and it perks them up, and then you see that they start getting sleepy or somnolent or lethargic again, or might have respiratory depression again when it wears off. The antidotes never last as long as the actual medication. So those are the other signs and symptoms depending on the category of drug.